Assalamualaikum and a very good day, everyone. So, I'll be talking about anesthesia for elderly, what's new. So, I make this recording so that I can explain more and a little bit slower pace. So, for those of you interested to know about anesthesia for the elderly, and I'm gonna tell you what's new in this area of geriatric anesthesiology. Okay, so first let me introduce myself. So I'm Dr. Abdul Jabbar. So I'm anesthesiologist and critical care specialist, and currently working in UC Malaysia Sabah. But I'm also doing my clinical work in the ICU and the OT operating theatre in the Hospital Queen Elizabeth II. Okay, let's move on. So as you all know, the world is going to becoming an aging world. So the almost 25% of the world population will be old within a number some amount of years ahead. Okay, so as near as 2050, 60% of people all over the world will be 65 years of age. In fact, now many countries have already become age nation like Japan and many countries in Europe. Okay, so they're already becoming age. So more elderly people rather than the young people, and they are also the dependency ratio also is becoming a bit of troublesome in their country. Okay, so let's move forward. So usually people say age is just a number, but is it? But one thing we know, aging is a certainty in life. But what is the definition of aging? So age cutoff for elderly can be either 60 or 65 years old. If you see United Nations definition says more than 60 years old, and WHO says more than 65 years old. But it really depends on what source and what article you read and what are the different sources that you refer to. But mostly, almost all will say is either 60 or 65 years old as the age cutoff for elderly. Okay, so when we talk about geriatric anesthesiology, there are certain aspects which are timeless knowledge and other aspects require more updates as research finding emerges. Okay, so the timeless knowledge that we already know and probably going to be true towards the future and probably might not change there very much because by now we already know the physiological changes in elderly that will happen. So first, usually when we talk about central nervous system, there will be a definite cognitive decline, and because aging is associated with a progressive decrease in brain mass with increased ventricular size. Okay, so there's a relative change in the size of the brain mass and the ventricular size. So the cerebral blood flow and cerebral metabolic rate, electrical activity remain unchanged. So this is actually related to the how much function of the CNS that we use, how much function of brain we use. So if we are keeping ourselves cognitively active, we will become all the CMR electrical activity will remain unchanged. Okay, so and as a person age, the neurotransmitter also function will suffer due to decreased number of receptors like acetylcholine, dopamine, serotonin, noradrenaline, 5-hydroxytryptamine, and so on. So hence there is a decrease because of these reduced receptors and also neurotransmitters. There is a decrease in minimum alveolar concentration (MAC). So it means that the brain of an elderly patient will become more increased sensitivity to general anesthetic drugs. So this is related to the reduction in neurotransmitters. So it's very easy to inhibit the central nervous system. So it's easier to make them fall asleep to induce general anesthesia in the patient. So we have to be careful with the MAC usage. And sometimes in certain anesthetic machine, you can adjust the MAC according to the age. But this is just an estimation by the machine in the GA machine. Okay. So due to decreased Schwann cells, there is an increase in the exposed nerve root distance. So the nerve, because when we block using the LA, we actually block the node of Rambier, and then the Schwann cell will be shrinking, and there will be so when we give block, the block sensitivity will increase, means the block can last longer. It's even more intense in elderly patient. Okay, so there is also a decrease in the epidural space due to narrowing of the spinal canal. Okay, so when we give a small amount of the neuraxial anesthesia, the effect can be more exaggerated and more pronounced. So because of this effect, we have to be careful with our drug usage. We have to control the drug usage. Pharmacokinetic and pharmacodynamic definitely will be a bit different, and also the dosages. Okay. All right. So we talk about the cardiovascular changes. So there will be decreased efficiency overall of the function for the overall function of the heart and also the cardiovascular system. Okay, anesthetic agent in elderly individuals remove the baseline sympathetic tone. So when we administer anesthetic agent, either IV or volatile agent, so they abolish the sympathetic tone. So then after that, they directly depress the myocardial and vascular smooth muscle contraction and diminish the baroreceptor reflex, leading to unpredictable responses. Sometimes they can be very tachycardic, sometimes they can be hypotension, tachycardia. Okay, so the changes in vascular compliance, okay, the blood vessels, myocyte death, receptor responsiveness, decrease the reserve and adaptability to alteration during major surgical procedures. So their reserve becoming lower, they can't cope well with changes in the blood volume, okay, the blood pressure becoming more labile, so it's become harder to control. But every time you give the drugs, the response will be exaggerated. Okay, so vascular aging occurs with loss of elasticity of vessel and stiffen the arteries, and subsequently pressure in the aortic root increases during late systole and resulting in ventricular hypertrophy. So you can see many of them have ventricular hypertrophy and will have impact diastolic filling. The venous compliance decreases and the stiff veins are unable to buffer changes in blood volume, leading to exaggerated changes in cardiac filling pressure. Okay, so cardiac filling pressure will be markedly different during volume shift. Okay, so in the end, they will be increased susceptibility to hypovolemia. All right, so uh, as a person age, there will be progressive reduction of the sinoatrial node cell, and then they will have increased incidence of atrial fibrillation, and they will have many kind of arrhythmia, but usually the one that we usually see in them is atrial fibrillation. Okay, so because of the fibrotic infiltration of the heart, as the person become aging, there will also be ventricular hypertrophy, like I said before, and will cause diastolic impairment and diastolic dysfunction. Okay, so especially those can be markedly seen when patient age above 75 years old. Okay, so diastolic filling depends on high left atrial pressure and atrial kick, hence tachycardia and atrial fibrillation is not tolerated well. So there is narrow range between inadequate filling pressure and fluid overload. Okay, so the safety margin of fluid administration becoming very narrow. So they can't cope with too much fluid because of the diastolic impairment, but also they need when the volume becoming lower a bit, the feeding pressure will be inadequate, so they are the margin of adequacy of fluid volume is very narrow. Okay, so then we talk about respiratory system. They will have general respiratory insufficiency, and the elderly have altered respiratory mechanics and less efficient gas exchange. And because the intrapleural pressure increases because of the increased lung compliance, stiff thorax, decreased height and calcification of vertebrae, and diaphragmatic flattening. There is a decrease in central nervous system responsiveness that causes blunted response to hypoxia and hypercapnia. Okay, so because of the central nervous system changes that I've told you just now, the the brain responsiveness towards hypoxia, hypercapnia, like to increase the ventilatory response, minute ventilation, will be blunted. So of course, when this is blunted, coupled with addition of anesthetic agent, it will become even worse for the elderly to cope with hypoxia and hypercapnia. So when we talk about the volume of the lungs, elderly patient usually has a reduction of vital capacity, and there is an increase in residual volume. So when residual volume increase, there will also be this is due to reduced elastic recall 5 to 10% per decade that you can see in them. And there will also reduction in functional residual capacity, reduction in dead space, and reduction in closing capacity. But the reduction of functional residual capacity will be the degree of reduction will be more than reduction of closing capacity. So until a point, the closing capacity will become higher than functional residual capacity. So the lungs closes first before it reach the functional residual capacity, and this cause ventilation profusion mismatch and VQ mismatch and shunting. Okay, so there also you can see in elderly patient there is a limited maximal expiratory flow rate response in during exercise. Additionally, there is a reduction in the forced expiratory volume in 1 second, FEV1, every 6 to 10% per decade, you can see, and FEV1 over FRC. And in elderly patient, you can also see blunting of hypoxic pulmonary vasoconstriction with HBB reflex, and they will occur with a decrease in pulmonary capillary bed and increase in pulmonary artery pressure and pulmonary vascular resistance. So you can see incidence of pulmonary hypertension increasing in them, and there will be poor response to hypoxic pulmonary vasoconstriction. And then they also have a decreased efficiency of gas exchange occurs due to breakdown of elastin connections between connective tissue and alveolar tissue. Poor tethering of the lung tissue to airways permits atelectasis and increases risk of hypoxia and pneumonia. So the smaller airway will collapse under anesthesia because of the higher closing capacity compared to FRC, and this will increase shunting and dead space. So because of these changes, pre-oxygenation before anesthesia takes longer time due to decreased partial pressure of arterial oxygen (PaO2) by approximately about 0.4 millimeter mercury per year. As you can see, the usual formula that you know, PaO2 equals to 100 minus 0.4 times H in years in millimeter mercury. Okay, so uh, when we look at the kidney, there will be some degree of nephrons reduction. Glomerulosclerosis occurs leading to decreased GFR after 40 years of age, and it will reduce about 10% decrease per decade. The drug clearance is decreased owing to reduced renal blood flow. Serum creatinine is a poor indicator of underlying renal function due to decreased muscle mass. Okay. Reduced sodium conservation owing to reduced renin aldosterone activity with risk ADH leads to hyponatremia and hyperkalemia. Certain endocrine abnormalities such as hypocalcemia, osteoporosis, and subclinical hypothyroidism with risk TSH can be seen. Okay, so uh, so nephron reduction pula salah. Okay, so in the musculoskeletal system, gastrointestinal system and the skin, they can have anemia, they can have reduced bone marrow production, they have a reduced spleen size, stem cell aging, erythropoietin resistance that leads to anemia. Decreased muscle mass and bone density, osteoarthritis, osteomalacia, rheumatoid arthritis, gout, degenerative joint disease, and a lot of other joints and bones become broken. So they have structural instability, they have reduced muscle mass, many of them have malnutrition, either overnutrition or undernutrition. And understanding of all these physiological changes will shape pragmatic approach on a case-to-case basis. So, as you all know, pharmacokinetic and pharmacodynamic in elderly also has been discovered, and changes is also that we know now. So they have increased sensitivity to anesthetic drug, like I said just now. The neurotransmitter reduced, so it's easier to block the CNS and cause anesthesia. So you need to be careful with the dose that you use. So they have reduced receptor number, increased receptor sensitivity, and post-receptor transduction in the brain. Hepatic metabolism and renal drug clearance is also affected, so they will affect the availability of the drug in the blood. So there is rapid equilibration with the peripheral compartment due to decreased total body water, and they have fast rising peak concentration and slower distribution. And as you can see here, this is the example of certain drugs in the elderly where they have decreased VD, decreased clearance in thiopentone etomidate, they have decreased clearance for propofol and midazolam, they have decreased clearance for morphine. So, and this is pharmacokinetic effect, and all the opioids, they have reduced central compartment volume, okay, because they have a decreased total body water, okay. All right. So they have decreased total body water. So there rapid equilibration between the peripheral compartment due to decreased total body water. So because of this, they have reduced central compartment volume. So their pharmacokinetic also differs. So neuromuscular blockers, they have prolonged action of drug undergoing hepatic metabolism. So like rocuronium, okay, those are unchanged usually. So new stick mean they have pharmacodynamic have more cardiac effect. So in the pharmacodynamic effect, all the anesthetic agent have increased brain sensitivity, reduced renal clearance, and the others are also have increased brain sensitivity. So you need usually that what we need to reduce the dose and we need to give it more time to for it to act. So these are the what do you call the reference, the QR code. Okay. So the update is we now know that all these physiological and pharmacological changes doesn't really tally with chronological age. So we need to assess the elderly patients on an individual basis. So this is the update. So this is what's new. So we now know over the last past decade. So we now know it doesn't really tally with the chronological age. So age is still just a number. All right. So to understand further what the elderly need, what are they what do they want? What is their what's the focus that they want? So I went to last year. I went to National Conference on Aging 2022. So to know further insight on what are the patient elderly themselves, what do they want? So in the conference, they talk about intergenerational support and labor participation among older people in Malaysia, and a lot of other discussions among the researcher in Malaysia that research on the elderly. So during the conference, there were recurrent theme involved like preservation of daily function, labor participations by the elderly. So this elderly patient, they actually want to participate in the labor force. Okay, so they also definitely they want quality of life, not just surviving. So the primary goal in anesthesia delivery in elderly patient should be not just survival. We should not look only at mortality and surviving. We should have the primary goal in anesthesia delivery in elderly patient to provide an optimal quality of life after the surgical procedure. So this is what we should be aiming for, not just survival. We should be aiming for optimal quality of life. Okay. So as if you can see all this QR code, this is the reference for the this is the QR code link for the references that I'm using during the talk. Okay. So when we talk about what type of patients, elderly patient at risk of harm following elective surgery. So if you can see, this is a systematic review and meta-analysis by Jennifer Ward, which includes 44 studies and involving 12,281 elderly patients. So we want to see and deep dive into identifying which type of older individuals at risk of harm following elective surgery. So we look into this systematic review and meta-analysis. So this is actually quite a recent uh, systematic review and meta-analysis. So recently published in 2019. So from this huge study, we know that the prevalence of post-operative complication is quite high actually in elderly, 25%. And 1 in 4 elderly will develop complications. So this is 25% complication. Okay. So you can see here prognostic factors for post-op complication among older adults undergoing elective surgery. So there is actually age itself does not predict the post-operative complication. What we want to know among this elderly patient, what are the factors that lead to postoperative complication? So it's things like poor performance status. So whatever that could predict a bad post-op outcome in the in an adult population, non-elderly patient, is still going to be true for elderly patient. Things like poor performance status, like poor functional capacity, max less than 4, smoking status, uh, independent activity of daily living impairment, cognitive impairment, ADL impairment, geriatric depression screen, and comorbidity score, poor mobility, and so on. But for specific for elderly, if you can see in this list of prognostic factor, you can see cognitive, frailty, geriatric depression screening, all is very specific for the elderly population. But what I want to focus in is here in approaching patient in elderly is actually what's new is that we should tailor our approach towards the frail elderly patient. Okay. So in addition to assessment of functional capacity preoperatively, usually when we see the patient preoperatively, we want to see their functional capacity and preoperatively, regardless they are elderly or normal adult. So, but in elderly, we need to, in addition to assessing the functional capacity, we need to assess the frail severity in elderly patient. So, the first frailty scale that was created and validated and tested was the frailty index. So, it compasses this five characteristic, and 3 out of 5 criteria present. We can actually identify it as frailty phenotype. And there's also Edmonton Frailty Scale, which is the most widely used scale for detecting frailty in elderly patient, and it also is available as a apps in App Store, so you can download and use it in your daily practice. So why this is important? Because frailty is actually a better representative of biological age rather than using chronological age. So the odds ratio of patient have is when the elderly patient is frail, they have higher odds ratio by 2.6 times higher to develop post-op complication. They are less likely to be discharged to their home. So this is comparing the frail patient to the non-frail in elderly population. So they will be less likely to be discharged to their home. They will have increased mortality. They will have increased use of long-term facility. And if you add this frailty scale into ASA classification that we always use, it will improve predictive power of post-op complications. Okay, so it will also increase length of stay, post-operative morbidity, and financial burden on the hospital. So these are the things that we need to focus on. So when you have elderly patient, don't just look at the number of the age, but we need to actually tailor our approach, and we need to identify the frail patients better. Okay, so frailty in elderly is actually a modifiable risk factor. So how do we modify this risk? Okay, so for elective surgery, we actually there is a growing evidence that we can employ prehabilitation. Sometimes people refer it to enhanced recovery after surgery, so they do prehabilitation before the surgery. So prehabilitation is actually a term where we increase the reserve, we improve the physiological reserve, we increase functional capacity, we improve the functional status of the patient. So if you can see at this graph, so the purple line is actually the uh, imaginary line of the level of independence of the patient. So if you can see here, if the patient does not undergo prehabilitation, so after the surgery, the functional status will drop, and after some time, it will recover, but it will not recover back to it may or may not recover back to 100%. So if you can see here, the orange color shows that it may not recover to 100%, and the purple color shows uh, it recover back to 100%. And the green color, sometimes some patients have three possibility lah. Some of them recover 100%, some of them recover less than 100%, some of them don't recover very well. They have even below the line of dependency. So by employing prehabilitation, we increase their functional status before the surgery itself, and then when they have the surgery, the functional status will be dropping, but when they recover, they have a better chance to return back to 100% functional status. Okay, so how to approach and employ prehabilitation? So I have given this talk before. So you can see this James Duran framework of prehabilitation involve a triad of physio and occupational therapy, proper nutrition, and improvement of cognitive and behavior for the elderly population and for the prehabilitation. So in case patient coming for emergency surgery, so you need to employ risk reduction strategy where you need to ensure that you use a proper dose adjustment, shorter anesthesia duration. You need to choose your anesthetic choice properly. I will talk about it after this. and we need to control the temperature because they probably have a poor temperature regulation, and you need to adjust the management according to organ dysfunction of the patient, and you need to choose the appropriate post-op care location, whether the patient will benefit more if they admitted to the ICU, or you can just go back to the ward. Okay, so next we talk about another aspect other than frailty. So way back before in 1887 in British Medical Journal BMJ, so they even say there are certain number of cases where there was a insanity following the use of anesthetic in operation. So they say the people become crazy, okay, after receiving anesthetic agent. So now we know that this is what we call now as a emergency delirium, then post-op delirium, and becoming post-op cognitive dysfunction. Okay, so these are the timeline that we want to see after the operation in the PACU 24 to 72 hours post-op and weeks to months. Okay, and another way of looking at it, the post-operative delirium, and then is also a risk factor for post-operative cognitive dysfunction. This is what we think we know before lah. Okay, so post-operative delirium can lead to prolonged hospital stay, higher mortality, PTSD, and also we think before this we think that it is a risk factor for post-operative cognitive dysfunction. But a recent study by Dailo LA so et al. So he said that uh, the postoperative delirium and longer term postoperative cognitive function may be different disorders. So they may or may not be related. Okay, so they may not be they may or may not be related. But it's very important to tackle and understand both postoperative delirium and post-op cognitive dysfunction. Okay. So when we talk about post-op cognitive dysfunction, there are many people suggesting in correcting the term itself of POCD. So maybe it's better to be used delayed neurocognitive recovery, post-operative neurocognitive disorder, and so on, instead of saying post-op cognitive dysfunction. But we were trained and we know that it's a post-op cognitive dysfunction is a term that we always use before. Okay, so these are the term, the new term is suggested to be used. Huh? Okay, so when we talk about post-op cognitive dysfunction, then we want to talk about what can make a difference. So this is the review done by Brodier, and it shows that the strength of evidence strong, moderate, and weak. Okay, so elderly actually at the mostly at risk for post-operative cognitive dysfunction. Okay, so at advanced age, lower education status, previous history of stroke, postoperative cognitive dysfunction at hospital discharge. Okay, and then I want to talk about the importance of using EEG guided anesthesia and the use of dexmedetomidine. Okay, so as you know, there are other factors that are showing moderate strength of evidence like respiratory complications post-operatively, intraoperatively, postoperatively will also lead to POCD, and post-operative infection also can lead to post-op cognitive dysfunction. The longer duration of anesthesia also can lead to post-operative cognitive dysfunction, and reoperation also will make increased risk, higher risk for POCD. And the other factors that will decrease the risk is this one lah, EEG guided anesthesia using base, dexmedetomidine, and maybe use propofol, ketamine, or NSAID. So we'll go one by one after this. Okay. So we talk about EEG guided anesthesia. So in 2018, back in 2018, at that time, TIVA has been said to may reduce POCD by odds ratio of 0.52, almost half. In this Cochrane review conducted in 869 participants. So at that point of time, TIVA was thought to be the thing to reduce POCD, and because POCD is very the thing that is very fearful or feared by the elderly patient. Okay, because they can have clouding of mental, their thinking is not good, they're becoming forgetful and so on. Okay, so at that point of time, people thought TIVA, using propofol, okay, total intravenous anesthesia, not using gas, probably the answer, okay. But then, uh, more and more evidence comes out after that, which says in the study by Micha and also Chow, so she says that sevoflurane increasing the incidence of POCD at 7 days and 9 months post-operatively. Okay. Then after that, when more and more study being conducted, that now we know that regardless of using gas or propofol, it is actually most likely that there are moderate quality evidence that optimize anesthesia guided by process EEG indices in non-cardiac surgical and non-neurosurgical procedures. So when you use EEG guidance, like using BASE, it could reduce the risk of post-op delirium in patient aged 60 years or over. And post-op cognitive dysfunction at 3 months could be reduced in this patient. The effect on POCD at 1 week and over 1 year after surgery is uncertain. Okay. So it's not the matter of using propofol, Tiva, or gas. It's the matter of using them correctly. So in elderly patient, whether you use anesthetic agent, propofol, Tiva, or gas, volatile agent, sevoflurane, it doesn't matter so long that you control the EEG value so that you do not deepen them too much. Okay. So there are more studies coming up after that, after 2018, and this is the latest one in 2022, where it shows effect of anesthesia depth on postoperative delirium and post-op cognitive dysfunction in high-risk patient, systematic review and meta-analysis. So in this 2022 published SR systematic review and meta-analysis, they shown that in 15 studies pooled involving 5,392 patients, when they compare high BIS 45 to 60 versus low BIS 30 to 40, it favor reduction of postoperative delirium and post-op cognitive dysfunction at 3 months. So now we know that if you are doing a case for elderly patient, you need to use BIS, regardless you want to use as you want to do Tiva, Propofol, or you want to use sevoflurane. Okay, so you need to use BIS. The higher the age, the more indication to use BIS. If the patient is frail, it's even more indicated to use BIS. Okay, so uh, as you know, Presidex, dexmedetomidine, uh, in this study done by, I think the animation is gone wrong. Okay, so dexmedetomidine has been found out to reduce uh, postoperative delirium and post-op cognitive dysfunction, especially the POCD. Dosage of the dexmedetomidine used from zero point 0.5 to 1.5 milligram per kg loading, followed by infusion of 0.5 to 0.8 milligram per kilo per hour. So usage of perioperative dexmedetomidine from the start until after the operation, treatment is associated with post-operatively with significantly reduced incidence of post-op cognitive dysfunction and reduced inflammation by they look at the TNF alpha and also interleukin 6, and they also have shown to have better neurocognitive function in comparison when they compare dexmedetomidine with both saline controls and comparator anesthetic. Okay, so next we talk about pericoxib. Systematic review and meta-analysis have been done where it shows that perioperative use of pericoxib was effective in treating early post-op cognitive dysfunction within 7 days, and they reduced the interleukin 6 and S100B concentration within 2 days after operation. So this S100B is being touted as the biomarker that can quantify how bad is the damage and cognitive dysfunction will be to the brain. So S100B is currently being studied as a good biomarker to predict or determine and predict the outcome of post-op cognitive dysfunction. So in some of the studies, they use pericoxib and they can see the reduction of S100B concentration within 2 days after the operation. Okay, so next we talk about GA versus RA. So back in 2018, Cochrane review, this is quite a popular Cochrane review, okay? So at that time, high quality evidence that regional blockade reduces pain on movement within 30 minutes after block placement. There is moderate quality of evidence for a decreased risk of pneumonia, reduced time to first mobilization, and reduced cost of analgesic regimen. So this is back in 2018. So they say RA is good. Okay. Reduce pneumonia, reduce time for first mobilization, reduce cost of analgesic regimen. Okay. So then comes multiple meta-analysis and review, and then they say RA and GA now it's almost the same. So it's the matter of what you do, how you employ it. But I want to share with you an update in February 2023 of systematic review and meta-analysis, where in the paper they suggest that r- regional anesthesia reduces intraoperative blood loss, length of hospital stays, and duration of surgery. However, the important primary outcome and in terms of safety, like post-op delirium, POCD, post-op cognitive dysfunction, mortality, and other safety outcome is still the same. Okay, so so it actually probably doesn't really matter whether you use regional anesthesia or general anesthesia. It just matter that you employ uh the method correctly. Okay, so if you do GA, you need to adjust the drug dosage properly, wait for the action first, because we predict the action will be slow and will be delayed, okay, by response to the drug, okay. But if you use RA, you need to also adjust your dosages of the LA, local anesthetic use, because they have reduced one cell, their sensitivity become more and the action will become prolonged. So you need to be careful for both method for when you want to employ it in the elderly. Okay, so in one of the new updates from the literature is that there's this long-term outcome of mortality after cancer surgery with regard to GA. So at one point of time, you can see there are many articles that suggest that propofol may lead to benefit of mortality in cancer surgery and reduce risk of recurrence. Okay, so in this long-term survival study, after major cancer surgery, the survival was similar between IV anesthesia or volatile anesthesia. So propofol-based IV anesthesia should not be used for cancer surgery with the expectation that it will improve overall or cancer-specific survival. And then when we talk about approaching geriatric population in giving anesthesia, so this is the nice article uh, written by Mahender uh, when he talk about recent advances in geriatric anesthesia. So for your elderly patient more than 65 years old, you need to conduct a comprehensive geriatric assessment in this patient because they have multiple comorbidities. You need to optimize the comorbidities properly. Okay, so one of the interesting thing that been come up now is to do this test of time up and go. So patient wears their regular footwear and can use walking aid and so on. So patient begin by having a patient sit back in the standard armchair and identify a line of 3 meters on the floor, and then you ask them to walk, and then you count the time. So if they unable to finish the 3 meters within 20 seconds to complete, so it shows a tendency of patient to be frail, and you need to perform comprehensive geriatric assessment and detect the do the I mean perform the frailty assessment tool to assess whether the patient is frail or not. So you need if you uh, if you identify them as frail, then you need to uh, perform comprehensive geriatric assessment, okay, and then perform comprehensive geriatric assessment, and then you can proceed appropriately lah. So as I say in what I said before, you need to tailor anesthetic technique. Maybe peripheral nerve block where indicated, you can use with GA or without GA if appropriate. Then you need to use depth of anesthesia monitors, EEG base. You need to use the goal directed fluid therapy. and restrictive transmission therapy, minimal invasive technique, adequate care while positioning because of the muscle mass is reduced, body point is more prominent, they can have pressure ulcers and so on. Okay, and then uh, you need to evaluate and exclude many things, comorbidities, evaluate drugs because they have polypharmacy, and you need to assess for postural hypertension or syncope, initial, and then you need to employ initial prehabilitation. You need to ask about social support, and postoperatively need to assess and manage pain appropriately, assess and treat postoperative delirium because they have increased postoperative delirium and POCD. And then you need to do early mobilization, early feeding, thromboprophylaxis, and you need to use consistent antimicrobial administration. Okay, all right. So there's also a perioperative management of elderly patient prime recommendation from Italian Inter-Society Consensus, which is quite good. Then you can also follow. This is published in 2021. And they have a long list of recommendations and so on that you can follow. So these are the QR code. And then one of the key point is that the first one on top, and also moderate evidence and recommendation of A is to do this time up and go, and to look for whether they can complete the 3 meters walking within 20 seconds. So if they cannot make it in 20 seconds, you need to do the comprehensive geriatric assessment, and then you may or may not, you may involve geriatrician to help you as well. Because this type of patient, if they cannot complete the test, TUG test, time up and go, they most likely to be frail. So in summary, a simplified approach to incorporate new updates. You need to understand the timeless concept and timeless knowledge, which you need to understand the physiological changes that will shape pragmatic approach on case-to-case basis. You need to ensure all comorbidities are well optimized as per usual practices. You need to screen for frailty. You need to start with TUG more than 30 seconds, then Edmonton frailty scale to identify these patients which are frail. Okay, so when the patient are confirmed frail, or they are more than 80 years old, or they are poor meds, they need to undergo prehabilitation, and they need to undergo comprehensive geriatric assessment, and involve geriatrician is needed. So you can follow back the prime recommendation or the article just now that I shared. So GA versus regional, not enough data yet. Maybe based on the latest meta-analysis and systematic review, uh, they do regional anesthesia does not improve the important outcomes like mortality, post-op complication, readmission, okay, and morbidity and so on. But they are starting to show a little bit certain things of minor outcomes. Okay, so maybe not enough data yet, but what we do know is that we need to employ the GA or regional appropriately in this type of patient. So we need to be good at it. So if you are good at GA, you need to be good at GA in particularly in elderly patient. If you are good in regional anesthesia, you must be very good at the regional anesthesia. So if you say regional anesthesia is very good for elderly compared to GA, okay, if you are not good at regional anesthesia, you may cause more harm to the elderly because their sensitivity to local anesthesia is higher, their muscle mass is lower, their fat many elderly, their fat level is low, so the distribution, the injection, the level of block may be totally different. Okay, so in general anesthesia also, if it's being employed properly, using base, using proper dose, and so on, it may be a safer technique than regional anesthesia. So as of now, it's not enough data yet to whether to highly recommend either one. So it depends really on the patient situation and patient case to case basis. So if you have a frail patients and at risk of post-op delirium and post-op cognitive dysfunction, you need to optimize the work process, and plus ask for a skillful surgeon so that shorter GA duration and lesser risk. Okay. TIVA versus volatile, which one better? Conflicting data. So until now, we know it doesn't really matter whether you use propofol or volatile agent. But what we do know now, what is having the highest certainty of evidence is that you need to use BIS and targeting a slightly higher 50 to 60 rather than 40 to 60 to get anesthesia depth uh, for both IV and volatile agent. So this is especially for patient which is frail and also at risk of postoperative cognitive dysfunction. Okay, like more than 80 years old and all the other factors that I showed you just now. So you need to use BIS for them because you can't really rely on the MAC value or the whatever you use for to ensure the TIVA is adequate because this kind of patient, if you know the physiological changes, pharmacokinetic and pharmacodynamic changes, they are more sensitive to this drug and they are more uh there is unpredictable also and they are more sensitive and they can be deepened way more deeper than the same dose that you use for the adult population. And then you need to use opioid free or opioid sparing anesthesia wherever possible. So this is where the regional anesthesia can be helpful, okay, to reduce the opioid. So we know opioid is not good for the elderly, so we try to we try to remove it as much as possible. And perhaps we may want to try to use dexmedetomidine perioperatively because it's been showing a good and promising evidence. And you need, then maybe if we can use, you can use prednisone if not contraindicated for them to use. Okay, so but this is the evidence is still not that good yet, lah. Okay, all right. So anesthesia for elderly, what's new? So I hope you can use whatever that I've taught to you before, and that's all. Thank you. You can ask question in the YouTube comments. Thank you.